All right, we'll get started. Thank you again, everyone, for joining us. My name is Tricia Martinez. I'm the Senior Director for Clinical Transformation here at Glooko, and we'll get going. Let's see. All right, for a couple of disclaimers as we get started today, we're going to be speaking a lot about our clinic dashboard and our risk stratification. It is currently only available in select countries. And while this webinar is intended for our US customers, we're really grateful for our international participants. Anytime there's an opportunity to hear from Dr. Clemens, it's a great one. So thank you for joining us today. For our agenda today, we'll spend some initial time just doing a brief overview of Glooko as well as our risk dashboard. Then we'll be moving on to some of the challenges that we see in care delivery across different specialties, including primary care. And then we'll talk about how we can improve the utilization of population-based risk dashboards among those populations, and then talk about the future of evidence-based population management. So I want to first start out by introducing Dr. Mark Clemens. He is our Chief Medical and Strategy Officer who joined Glooko full-time about a year ago. Dr. Clemens has some significant research background and really grateful that he's able to join. So Mark, thank you so much for joining us today.
Thank you, Tricia. Happy to be here.
We'll first get started. I'll just share a brief overview talking about what Glooko is. Many of you may be familiar with Glooko as a product, but our goal as an organization is to transform the way that we are connecting patients, their providers, and especially their data. We are a global-based company, and we have a global platform, and we want to improve and simplify the care delivery for all of our patients, providers, and those who experience diabetes care. Oops. There's a couple of numbers that we'll share. You can see we have a fairly large global footprint. We're in over 30 countries, and we have a significant number of patient users, clinic users, and a tremendous amount of data that we receive on our platform. So we're very fortunate to be able to provide care really throughout the globe. We also integrate with more than 200 devices, and you'll see a QR code up at the top of the screen, and that will take you directly to our device compatibility screen. In addition to some of the CGM devices, which you see there, we also connect with a large variety of glucose meters, but we also connect with Apple Health, with Fitbit, Strava, a number of activity platforms and devices. So we have a very, very large ecosystem of devices that we integrate with. Some of the other things that I'll mention, and Dr. Clemens has really been involved in a lot of this work that was done by our clinical research team, but Glooko delivers industry-leading sustainable outcomes, both for A1C as well as beyond. Dr. Clemens, do you want to spend some time just talking it through this particular set of data that we have here to share?
Sure. Just want to mention that through a combination of prospective clinical trial work as well as observational studies, we've been able to show that use of the Glooko platform in conjunction with remote care leads to clinically significant reductions in A1C at both 3 months and 6 months, and decreased average glucose that mirrors that all the way out to 1 year, and increased time in range for blood glucose, and decreased exposure to hyperglycemia. And we've also shown through some observational work that when Glooko is discontinued, meaning when a person using the Glooko mobile app stops using the Glooko mobile app, patients experience a relatively rapid decline in glycemic control within 6 to 8 weeks. So they'll see their A1C, their exposure to hyperglycemia go up, their average glucose go up, and their time in range go down.
Thanks, Mark. That continuity is really important. Some of the things that Glooko does in terms of benefits for the healthcare system, and we certainly could spend a great deal of time talking about this. One of the things that I get most passionate about when I speak about the benefits of Glooko is the EHR compatibility and EHR integration. And I know that's something, Mark, that you are really passionate about as well. As a frontline care provider, I think one of the things that I like least is documentation. And so with our EHR integrations, improving the documentation time and the time that it takes to do your clinical documentation is really an incredible enhancement. I think it's probably one of the most significant things that I like to call out for our EHR workflows. But in addition to that, there's some great operational benefits of our EHR workflows that streamlines the process of care, of receiving the data and ultimately getting it uploaded into your EHR, really for many members of the care team. So whether it is your front office staff, your nursing staff, your provider staff, with Glooko and the EHR integration, it enables significantly more efficient workflows, which is always a win. Dr. Clements talked about the clinical outcomes that we achieve with Glooko, but we also have tied that as well to some of the economic outcomes. We know that anytime that we can improve A1C time in range, there has been a great deal of work around that, but it does translate into cost savings as well. Dr. Clements, did you want to comment or have any other comments on the cost savings in particular and how it was calculated?
Just to comment that a health economic model was created using calculations from the UKPDS data. While it's challenging to do these types of studies, we were able to show that use of the platform led to some reductions in comorbidities and complications given the A1C reductions over time that led to these estimated cost savings.
That's great. Thank you. We will jump in here. I'm going to provide a brief overview of some of the EHR integrations that I mentioned, mainly so that we'll be able to illustrate where you're going to be able to reference the particular risk dashboard that we're talking about. So real quickly, we have a number of different EHR integrations. The Glooko Patient Portal for Professionals is affectionately called our one-click, which allows providers and caregivers to access Glooko directly from the EHR. It will take you directly into the patient's record or directly into their Glooko chart, so to speak, and provides that seamless transition so you're able to access all of the great Glooko data within your current workflow. Both the PDF report and the flow sheet statistics flow into the EHR in very similar ways. The PDF will pull over those, the printed reports that your organizations designate as those that you want to pull over, and the flow sheet statistics will flow into the flow sheets area in your EHR. The beauty of the flow sheet statistics, and I think, I'm not sure if we'll dive into it too much here, but it provides discrete data which your organizations can then extract. Having worked many years as a quality professional, the ability to extract that data and add it to organizational reports really is a game changer in terms of how you can use the data to demonstrate improved outcomes. So that flow sheet statistic report enables a lot of the things that I mentioned previously. The other two features, creating the patient account logon and the single sign-on, are almost the invisible features, but help to streamline that work as well as provide secure access, which is certainly top of mind for our organizations. I'll also highlight here that our patient portal for professionals, it does leverage Smart on Fire technology, and it is available in the Epic showroom. So those of you who use Epic as your EHR, it's a very easily configurable integration that we're able to deploy fairly quickly. And I won't spend too much more time on that to say that we know that certainly is something that organizations are looking towards. And so we partner with Epic closely to make sure that we can streamline that integration as much as possible. I'll do a brief overview of the dashboard, and then we'll really dive in to hear Dr. Clements' insights about the research that was conducted behind this. This is our launch page when you originally will launch into Glooko from the web experience. And what you will see here, the dashboard overview is divided into 3 sections: the population metrics, the risk stratification, and then engagement. The population metrics are going to give you an overview of your overall total patient population, mainly based on numbers and the types of devices being used. So whether it be CGM meters, EG meters, whatever that might be, it will show you the percentage of meters used, along with the number of activated patient accounts. At the very bottom, you'll see the Glooko engagement. So how many patients have the different types of phases that they might be in their account, whether it's activated, whether you've sent them an email to join, and whether or not they've accepted or not accepted. You'll also see the types of sync methods. And one of the things that we are seeing around the globe with our data is the number of cloud-to-cloud sync data points really is increasing significantly, really since 2020. So you'll see here the different sync methods, and you'll be able to monitor and track that in your own organizations. With the patient risk stratification in the middle, I'm not going to spend too much time talking about this because Dr. Clements will speak more to it, but I will say that it stratifies patients according to risk and provides a really easy view for you to see your entire population, the types of risk, and really enables you to follow up with patients who are more likely to be at risk. Again, these are our population metrics that you'll see here at the top, as well as a little bit deeper dive into the engagement and the engagement usage. You'll see where it talks about the sync methods that will appear over a period of 90 days. And so you'll continue to see that. I think this information is particularly helpful as you start to implement Glooko, and especially if you're implementing EHR integrations, that you're able to monitor perhaps the adoption either from your patients or for the number of syncs that are in clinic. So this is helpful information in that regard. All right, Mark, I'm going to turn it over to you here. Risk stratification, I know you've been heavily involved in this as part of your clinical research efforts. So I'll have you chat a little bit more about this and give us some of the details behind why we went this direction.
Sure, thanks, Tricia. So the clinical risk dashboard based on CGM data is really derived from work that originated from researchers at Stanford University. The diabetes program there partnered with a lab called the SURF engineering team. They really conduct healthcare engineering. And what they did is go through multiple user-centered design cycles to identify a way to display information that gave clinicians and clinical teams insight into the risk or the current status of each individual in their clinic panel, so that without having to open one chart at a time, at a glance, they could identify who really needed extra help. And that extra help could take many different forms. In their case, they were primarily sending patient portal messages and making phone calls. The work that I will show you has been tested in recent onset type 1 diabetes and pediatrics, but I think you're going to instantly see how applicable it will be to adult diabetes, to type 2 diabetes, with some adaptation in the future to gestational diabetes. Wherever CGM is used, this dashboard will be applicable. And one of the things that the teams showed over the course of at least a dozen papers now is that they can reduce the amount of time it takes for a clinical team member to identify patients at risk who need additional help by 86%. So wow. That's really phenomenal.
Yeah, that's pretty significant.
The dashboard uses 14 days of CGM data to flag patients. And then, as Tricia showed in the previous slide, it sorts and ranks patients using color-coded alerts.
Great, thank you. I think we've talked about this a bit in terms of the clinical methodology that was used to develop our risk dashboard. Anything else you'd add to that before we jump to the next phase?
If you advance one slide, I can show you actually some of the data that were used. So in the research that was done, the dashboard was embedded into a program called the 4T program. And in the 4T program, they were able to show that after diagnosis, which is shown at the y-axis at the 0 time point in the graph on the left, that they could significantly reduce A1C all the way out to 12 months. So 1.1% reduction in A1C, that translates to 12 millimoles per mole of A1C in European units. at 12 months. And really the key that allowed them to unlock this was the clinic dashboard and the remote care process that went along with it. And you can see the paper that was published in Nature Medicine that showed these data.
That's
Next
great.
slide. They were also able to show that more youth achieved a target A1C of 7%. So what I'm showing you here are their historical data pre-implementation of the clinic risk dashboard, data from a pilot study where they first provided CGMs at a very early stage after diagnosis to individuals with type 1 diabetes. And partway through the pilot realized that they should implement this population risk dashboard based approach. And then what's called 4T study 1, where they had fully implemented this dashboard. And if you just compare the solid gray to the solid blue bars, you can see the increase month over month or quarter over quarter in the proportion of patients who are meeting the target.
That's great. We always love to see that kind of growth when we implement something. That's great.
Absolutely. So I'm just going to give you a couple of notes about where we think this dashboard can go in the future from the Glooko perspective. I've been privileged during my research career, which happened over 20 years prior to joining Glooko full-time this July, to conduct a lot of research with very talented colleagues, including colleague Susanna Patton. And one of the things we did early on in our collaboration is identify that a score called the mealtime insulin bolus score, which you can see described at the bottom, where an individual gets 1 point for each carbohydrate associated bolus within each of the 3 fairly standardized meal windows. They're pretty broad, and they can get 0 to 3 points per day. And then we average that score over a 14-day period to come up with the mealtime insulin bolus score. The score doesn't consider whether they've had any snacks or lunch, breakfast, or dinner outside of those windows. And it really doesn't need to, because the data you see on the left-hand side show that there's a very significant correlation between the bolus score and A1C all the way out to 12 months in a multivariable model that considered other clinical factors. And subsequent data that we collected showed that even if we created a variety of different scores using insulin dosing, so if we collected the total score for the day, the total number of boluses per day, if we collected correction boluses, none of those was associated with A1C currently or out to 12 months as this score was. So this is a candidate measure now for a future version of this dashboard, and that would bring insulin delivery data into the dashboard for the first time. Next slide. And then I've also been privileged to do work with a number of colleagues. You can see many, many colleagues listed on this manuscript to the right that was led by David Klonoff with the Diabetes Technology Society, and that describes the creation of the Glycemia Risk Index, or the GRI. And the methodology here was really quite interesting. So it was an answer to the time in range, which describes central tendency for glucose for an individual. But the Glycemia Risk Index really looks at the opposite. It looks at one's exposure to hypo and hyperglycemia and the degree of exposure away from the target range. And what they did is they created an equation that was derived from clinicians' percentile ranking of a number of different CGM profiles that they were presented. And I believe they had over 300 clinicians examining over 20 different CGM profiles each. And they were able to turn that into a mathematical model that really follows the level of concern that clinicians have when they look at a 14-day CGM profile.
Wow, that's a lot of data review.
Yeah. This also becomes a potential metric for the future. And you could imagine that instead of using multiple biomarkers to rank order the dashboard, you might be able to use a single metric like this and then examine which components of the ambulatory glucose profile are contributing to this risk.
That's great.
So this just shows you the glycemia risk index in action and why many people think that it's clinically relevant. So an intervention that improves glycemia will move a person from the upper and right-hand areas of the curve that you see represented with the red diagonal bars to the lower and left-hand areas of the curve over time. And you can see that the x-axis represents the hypoglycemia component of the GRI, and the y-axis represents the hyperglycemic component of the GRI. And they are weighted so that both of them are considered relatively equally in the GRI score.
Great. Are there any changes that would for pediatrics versus adult versus pregnant women, or is this a fairly similar graph in terms of distribution?
It's only been validated in adults with diabetes, type 1 and type 2. We are actually seeing an effort right now to validate this in pediatrics, and it hasn't been tested yet in pregnancy-related diabetes. It would most certainly be a different score, but that's important work that should be done in the future.
That's great. Thank you.
So this just shows you the risk dashboard with a little more resolution. You can see the current risk dashboard has multiple biomarkers. On the left, we're showing you 4 of them: exposure to extreme lows, exposure to the low range, exposure to the high range, and large drops in time in range. And there are actually 7 biomarkers that have been integrated into the dashboard so far. You can see that there's a hyperlink to access the full dashboard in the lower left corner. And the dashboard really starts with showing the % time that the CGM has been worn over the observation period, the time in range, a novel marker developed by the Stanford SURF team, which is the time in range trend that shows whether time in range is going up or going down in the current week compared to the prior week, and then some of the other ambulatory glucose metrics you can see on the right. And I have just placed little markers on this for GRI and bolus to show that those could easily be integrated as columns into this dashboard in the future.
Mark, I often hear from colleagues, primarily in primary care, that say, just tell me the one number to focus on. I think historically we kind of think of that as A1C, but do you see potentially GRE being that one number to focus on in the future, or is just curious what your thoughts are about that?
Yeah, you know, taking a novel biomarker and turning it into a widely accepted and scalably used biomarker is a little nuanced because it takes acceptance, right, and implementation across many centers. I think the GRI has a great chance of being adopted. I think it makes clinical sense. I think it's very logical. And as you can see, instead of using you know, multiple biomarkers on the left here to rank order this list, you could actually use one biomarker to rank order the list potentially, and then see what's contributing to the risk. That work really needs to be done. It's not validated to be used in that way today, but I see that as the next important research for the field to conduct.
That's great. Look forward to that research. That'll be great. So transitioning a bit into some of the challenges across diabetes, one of the questions, you know, as we were thinking about what to share, you know, we know diabetes impacts patients that receive care in all specialties of medicine. What are some of the challenges that you're seeing in areas that provide care to pregnant women, or particularly in primary care? You and I both know we're hearing a lot about both of those areas.
Yeah, if you go to the next slide, I've developed a list that really represents, I think, the comments I hear most often from primary care physicians, from those providing care to pregnant women with diabetes. So you can see in the primary care column that time constraints are really an issue, not so different from diabetes centers and specialty endocrinologists. The fragmented data ecosystem is a problem. There are unmeasured time costs from context switching. That can include context switching from going outside the EHR into another platform, or from having to go to 6 or 7 or 8 different platforms to find data. There is a significant care coordination burden, because a primary care physician may need to call in the troops, so to speak, from diabetes educators, may need to send somebody to a retinal specialist, may need to send somebody to a nephrologist, and so forth. They're managing that burden of care coordination. There tends to be intensification inertia. One of the easiest things to do in medicine, sometimes the right thing to do, but the easiest things to do are nothing to maintain the status quo. And so if you're a primary care physician and you've only got 8 minutes per visit, and it's going to require a complex conversation to tell somebody that they're going to go on to a second therapy or a third therapy for their diabetes, you may defer that conversation to the next visit or two if you're still rushed at the next visit, and then the individual is maintained on a therapy that may not be optimal for helping them to achieve their health outcomes for a number of additional months. There's complexity to modern insulin therapy, right? We have the alphabet of insulins out there. We also have the alphabet of technologies with many different insulin pump choices, multiple CGMs. And if you look out on the horizon, there are more CGM devices and insulin pumps that are working their way into various markets around the world. And remember, Glooko is a global company, so we are in many of those markets. Managing comorbidities can be challenging. There are psychosocial barriers and social barriers to health that have to be addressed. Engaging a patient both in achieving their health-related goals at home and in maintaining their follow-up appointments can be a challenge. And there's both a primary care and endocrine workforce crisis out there. I'll show you that in just a moment. But you know, gestational care has some of the same challenges and some distinct challenges, right? The availability of screening for gestational diabetes is an issue. It takes time and coordination, and a lot of women don't follow up with the screening, and so that can be an issue. For that reason, CGM devices are being used more and more often. There's a rapid treatment window. You only have limited time to impact the health of the unborn child to achieve glycemic control. Same data collection challenges. There's extremely low tolerance for hyperglycemia in the setting of pregnancy. There can be knowledge gaps for the gestational care providers when it comes to insulin management. There are additional comorbid conditions that also require rapid treatment, like hypertension in pregnancy, advanced maternal age that can raise the risk for the fetus and require increased monitoring. There's the psychological stress of being a pregnant individual, the time-consuming counseling that can elicit, drop off from follow-up, and again, social barriers to health.
Yeah, that's a lot. I think too, when I was going through nursing school, we certainly did not learn about all of the different individual devices. And I think that is probably true of medical school as well, that just the general understanding of what these devices are is certainly a challenge as well. But that is quite the list.
So fast. They're moving so fast. They didn't exist when I was in school.
That's great.
So this calls back to the comment I just made. There are too few specialists across the U.S. to manage diabetes. Here you can see a map that shows the U.S. counties with one or more pediatric or adult endocrinologists, and the U.S. counties with one or more primary care provider. And it's amazing to see that there are counties scattered across the Great Plains and the Upper Great Plains in the U.S. that have no primary care. So the distribution is a problem, as well as the volume. And we're seeing a workforce crisis now where there are fewer people entering the field of endocrinology, both in the adult and pediatric space, than there are leaving the field from retirement. So there are declining numbers.
Wow. Yeah, that's a little terrifying to think about, just even taking into consideration what current wait lists look like for endocrinologists in particular. Can't even imagine what the future might hold there. Certainly a challenge.
And again, this just calls back to the problem I just mentioned, that if you measure the distribution of specialists, there are almost 35% of counties covering 22% of the nation's population, and they are considered a special risk for access to healthcare. And you can see on the right-hand side that endocrinologists tend to live near their training hospitals, which tend to be in urban areas. And there's a higher prevalence of diabetes across the Southern Belt, and you can see there's a tremendous mismatch there. So
Yeah.
The availability does not always match the need.
Yeah.
Next slide.
Absolutely. So switching gears a bit in terms of how we can improve utilization, I think anytime we get a new tool in place, sometimes it can be a little bit tricky to use. But I'm curious, what are some of the positive changes or abilities that you've seen in diabetes care delivery as population-based risk dashboards have been implemented? And what do you see really as the benefits to patients and the providers?
Sure. I'm going to give you two examples of benefits that we've seen. So one of them comes from my clinical academic career. It didn't use the CGM-based risk dashboard that I just showed you in its entirety, although that was a component of multiple dashboards that we used in our work in the Midwest. In this case, we had worked with a payer in the Midwest region to develop the first subspecialty value-based care program of its kind in U.S. pediatric care. And we were able to show that by implementing population health dashboards coupled with remote care practices where we could deliver care via the telephone or short video visits, remote patient monitoring style, we were able to see year over year that the highest risk portion of the publicly insured, this is the publicly insured population we're looking at here, the highest 15% of that population were able to receive one or more interventions from our clinic year over year. And you can see a year over year reduction in the median A1C. You can see a year over year reduction in the proportion of patients who had a median A1C above 9% for the year. And you could see that the percent of individuals with one or more validated admissions for diabetic ketoacidosis went down year over year. So population health management really works. I mean, I'm a pediatric endocrinologist, so I'm giving you an example from my own experience, but there are abundant studies in the adult world that, in type 1 and type 2 diabetes that show similar results.
Yeah, absolutely.
And then I really like this study that was done by the team that was evaluating the 4T program, because endocrinology programs had to leverage their diabetes education teams to make the phone calls and send the patient portal messages during the dashboard-driven remote care during that first year post-diagnosis for type 1 diabetes. And you can see that what they showed is that diabetes educators who were surveyed about their experience, and they surveyed nine diabetes educators here, I think, they were worried about the workload, as you can see toward the right-hand side there, but they were highly satisfied with the set of processes that were created and supported by a clinic risk dashboard, and in particular, the CGM-based risk dashboard that I showed you earlier. So this tells me that while there may be some hesitation by clinicians and their healthcare teams in implementing change in their practice to support population health management practices, once they do it, they find that their jobs are more satisfying because they can actually visibly see the improvement in health and in the quality of the care they provide.
Yeah, that's really important. It's always a challenge if we're adding to the workload and there isn't a perception that it's really been value added. And it looks like you were able to really capture that even with those additional components, it was an exceptional value that was added.
Yeah, and I want to emphasize this was by colleagues at Stanford. This wasn't my work, but I'm surveying the literature here for you.
Perfect. So kind of shifting over, Mark, I know you and I love to chat about the future and kind of the next steps in terms of evidence-based care and population health. So we have really been laser focused in on providing actionable tools for providers and healthcare teams. I know we've had a lot of discussions about this, but in your role as Chief Strategy Officer, Chief Medical Officer, what are some of the things that you think about might be needed for the future of population management?
Sure. Well, it begins with making sure that we're operating in the flow of work for clinicians and clinical teams. So you can see on this slide that electronic health record integration is important as the foundation for scalable population health management and diabetes. There are EHRs in practically every health system and small clinic across the country now. There is a concentration of use of one EHR. Many clinicians report EHR fatigue due to the volume of manual data entry they need to engage in. There are over $1 billion spent annually by health systems to integrate digital tools into the EHR. Clinicians and health systems are more likely to adopt an external digital health solution if it integrates into the EHR. And 84% of diabetes providers say they still have to download data manually and it doesn't integrate into their EHR. So if we want to scale this with a declining workforce and an increasing diabetes population, we really need to be present in the EHR. I just want to call that out as the beginning of the strategy.
Yeah, absolutely. And I know that you're really tuned into this too, but making sure that it is truly within the workflow that our clinicians are using. Yeah, and I love that we're taking that approach here at Glooko.
So these are some of the problems that I see have to be solved for clinicians to achieve scalable population health care. On the left are the problems. So cognitive burden is high for decision making. Shared decision making and education are time consuming, and we are time constrained during our clinical encounters. Changing patient behavior is challenging. So I don't know about you, Tricia, but whenever I try to develop a new habit, it's not easy. So if we're asking somebody to change a health-related behavior or to take on a new health-related behavior, you really have to do some work to identify the evidence that what you're suggesting will elicit a positive change in that health-related behavior. Documentation is a chore, quality is compromised. There are a lot of things that are pulled forward in clinical notes that aren't accurate. There are a lot of omissions because of lack of time and the desire to not spend as much pajama time, as clinicians call it, documenting before bed to get all the work in by the end of the day. Outcomes on any given drug or device therapy are variable. Not everybody gets the optimal outcome, even from a CGM or an insulin pump. And time is the most precious commodity that clinical teams have. So how do we solve that? Well, we solve that on the right by enhancing data collection, helping people in efficient ways get the right data that help them get to decisions faster and their documentation faster. We can get in front of clinical problems via predictive analytics. We can drive everything through a single EHR-driven workflow. We can pair population health dashboards, including health dashboards that have forecasting or predictive analytics that I just called out. We can pair them with evidence-based, digitally driven care programs that leverage health behavior change theory to try to help individuals with diabetes meet their own stated health goals. And precision patient engagement beyond the clinic walls is the way to do that. I believe in digital health tools and the promise that they bring for the future. And then part of those digital health tools includes making education available on demand. I mean, wouldn't it be great if we had a a Netflix-style recommender engine to say, you know what, it looks like you're having hypoglycemia on Tuesday and Thursday afternoons. Here's just a reminder of some of our clinic created education on how to manage hypoglycemia during and after exercise.
That would be great. This is no small list, that's for sure.
No, not at all.
Yeah, it's a pretty big ask, definitely. But in terms of the direction that we're going, it's great to see that. I know there's been a lot of thought put into it, both from your clinician hat as well as from your strategy hat, to really align these high problems and help to crosswalk how are we actually going to be part of the solution. So this is great.
So here I'm showing you a conceptual model for population health management and diabetes care. This is just the way I think about it. This has informed my thinking throughout my research career, and it's informed my thinking as I've come on board to Glooko as the chief strategy as well as chief medical officer. If you look at our clinic populations, we have individuals for whom we're providing care who have diverse risk and diverse responsiveness to any given therapy. And that is true for any given outcome. So you can see I've listed one outcome. That outcome could be risk for hospitalization. It could be hemoglobin A1C. It could be risk of nephropathy over time, et cetera. If we take all of the available information and we identify that information that leads to those precious drops of wisdom that we're seeking, then we can create population health dashboards that help us stratify the population into those who are low risk and can probably continue on with your clinic's standard approaches to care, and those who have higher risk. And for those individuals, we need to think about digital tools and health behavior change interventions as wrappers around the drugs and devices that we have prescribed for those individuals. I called out a moment ago that not everybody gets the optimal benefit on a CGM. So how do we help them get more benefit? Well, maybe it is, if the individual is a teenager, helping them to get more of those mealtime insulin boluses in by monitoring the mealtime insulin bolus score and sending them nudges prior to meals if they seem to be in danger of missing a meal bolus, and or enrolling them in a behavioral economic intervention that would help them get motivated externally by getting an incentive for getting those meal boluses, all kinds of things like that.
This is great. Yeah, Mark, when you and I were chatting about this earlier, and I'll call it out here, this is why I'm so excited to work at Glooko, because this type of work just is incredibly exciting. It also speaks to my clinical passion as a psychiatric nurse and working in community mental health for so long, because the things that you call out around wrapping around behavioral interventions and behavioral motivation is so critical to success for these chronic conditions, particularly diabetes. We know that. So this is one of the reasons I'm very excited to be here at Glooko. This is incredible work.
So it is also important that we take evidence-based strategies, right? We don't want to just implement health behavior change or care delivery interventions without knowing that they are likely to achieve the outcome that we are trying to achieve. So the way I think about this in diabetes is that in the US, the ADCES has identified 7 pillars of diabetes self-management that you can see on the left. And in order to help individuals achieve the outcomes they're declaring as important, we need intervention strategies that are psychological theory informed and that are based in evidence, that have some chance of working, of helping them meet those. And so you can see a list of potential interventional strategies that are coming from the health behavior change literature. But we can improve behaviors related to glucose monitoring, related to insulin dosing or taking other medications, related to choosing healthy items to eat or accurate carb counting or being more physically active and so forth. So any of these are targets for health behavior change intervention.
Wow, that's great.
And ultimately, what we want to do is achieve a smart system of care. So we want enhanced data collection that allows near real-time data listening, forecasting of near-term clinical outcomes so we can get in front of those clinical problems, risk stratification and actionable alerts that help the healthcare team connect the individual with diabetes with interventions that matter. And what I'm showing you here are not necessarily interventions that are specific to Glooko, but they are interventions that might be deliverable through a digital health application like the Glooko mobile app. They might also be deliverable in the clinic, and a platform like Glooko might be able to help one track the progress of an individual in that program, even if it doesn't interact with the Glooko platform. So that's the vision I see for the future, both for Glooko and for how we unlock the power of the data deluge and transforming it into the drops of wisdom that help us achieve smart systems of care.
That's great. Mark, thank you so much for your time and your expertise in joining us. For those of you who have any questions before we wrap up, please feel free to put them into the Q&A tab at the bottom, and we'll answer those as they come in. But yeah, while we wait and see if there's any questions, Mark, again, thank you so much for spending the time with us. I'm excited about the work that we're doing here at Glooko. There's a lot on the horizon. The problem list is extensive. We went over that. There's a long list of challenges to solve, but I think we've got a great team ready to tackle some of those.
Absolutely agree. And you know, if we're doing this well at Glooko, we're really helping all of the clinical teams out there to be more successful in achieving their goals.
Yeah, agreed. I don't see any questions coming in here yet. So if you do have any questions, we've got the emails listed here. We're happy to address any questions if you'd like to learn a little bit more about Glooko, or you have any questions on the material that's been presented. But again, thank you all so much for your time. We appreciate the effort that each of you made to set time out of your day to join us today. With that, we'll end our broadcast.